be on prescription drugs, generics, and I referred to it in my opening statement. GAO conducted a study, and my information is that it appears that they would say that a pharmacy may well be only reimbursed at somewhere around 64%. In my district, I have Caremark, and I think both Dr. Ferris and yourself know what Caremark represents. But I also have the Ortiz Pharmacy there in the west side of San Antonio, which is a poorer side and such. And I have visited both, and they're totally different operations. I assure you. But I do know that the Medicaid population in San Antonio is going to depend on Ortiz before it depends on others. And I guess I'm somewhat concerned. I don't understand the average manufacturer price. But the GAO report is very disturbing. How do you reconcile that? I mean, do you agree with the findings? Is there anything that you're going to be doing? And we're going to have testimony later from the private sector. But what is your understanding of that situation today?
Well, a couple things. First, I know that as we sort of promulgated the rules and as we talk about AWP, we're carrying out what we believe is the intent and sort of what needed to have happened as a result of the DRA. I think with respect to the details and sort of whether or not CMS believes that the GAO report was correct or incorrect or the impact, I would sort of defer that for the record. I mean, some of that gets very complicated. Our people who work in the Center for Medicaid and State Operations, who are the real experts, who are not here. I'd want to get you a fair answer and the right answer and not sort of dance around with it. So if to your indulgence, I'd like to defer that for the record.
And we'll follow up probably with a written question. And, of course, members of the subcommittee will be given time to submit written questions, and we would appreciate a prompt reply. The last question I have for you, of course, is if we come back to RAC, which I understand that you're simply saying we're following exactly what you and other members of Congress told us to do. Well, we understand that, but what we expect is that you're going to have some sort of a fair process that it's not just going to be efficient and effective, but obviously fair to the healthcare providers in this country. There has to be an incentive, obviously, and if it's contingency fee, then it's those overpayments. And maybe I don't understand, but they're also supposed to be looking for underpayments. Common sense and human nature would tell me that you may not have the same motivation or inspiration, and I could be wrong on that, to put as much effort in finding the underpayments. How do you address that particular side of the equation? And secondly, what is the incentive to identify underpayments?
The incentive to identify underpayments is exactly the same as the incentive to identify overpayments. The contingency fee, the proprietary fee that has been negotiated with the RACs is the same as a percentage of the overpayment as it is on the underpayment. So if they find a $100 overpayment and they got a 10% fee, they're getting $10. If they find a $100 underpayment and they got a 10% fee, it's $10. The incentives are the same. I always sort of, I take this next step lightly, sort of dealing with the chairman of the small business of the subcommittee, but we've done on a random basis for 10 years now, 11 years now, having nothing at all to do with the RACs, a random assessment under the Improper Payments Act of where Medicare makes improper payments. Completely random sample. It's not focused on overpayments. It's not focused on underpayments. We just take a strict sample over 10 years we've been doing that. And for the 10 years that we've been doing that, we do find that there are not a lot of underpayments. The vast majority of the improper payments, in the percentages you identified, 5 to 10%, being only the underpayments. We don't see a lot of underpayments as we look at those records and we go back and make a redetermination. Now, whether that's, I don't know how to explain that, whether or not the overpayments are the result of people trying to game, or the underpayments or the not having underpayments is the result of physicians or others just feeling like they don't want to bill for more for whatever reason. But we haven't seen over time a remarkable amount of underpayments as we looked at our improper payments across the program.
The last question is probably the toughest one for anyone that represents an agency or a department here. But under the leadership of the chairwoman Velasquez, who takes this responsibility very, very seriously. Under the jurisdiction of this committee comes the Regulatory Flexibility Act. And what we always ask heads of departments, organizations, cabinet members, doesn't matter. We always say, what do you do as you promulgate these regulations and such to take into consideration the mandate and the responsibility with which you are charged under the Regulatory Flexibility Act. One, it is applicable, I believe, and if you disagree, you would say, Charlie, we're an exception to the rule or something. But what do you do? Because it seems that has always been the hardest question for everyone to answer when we pose it.
Right. And, well, I don't know what this is going to say that I'm not quite sure it's that hard to answer, so maybe it'll be the wrong answer, but I'm going to try. And there's two aspects of this for us, right? There's on the demo side, there's a basic analytic due diligence function for us, right? So we knew we were doing the demo. We knew it was going to have an impact on a number of providers. There was not going to be any regulations associated with it. So the piece of the Regulatory Flexibility Act that talks about the assessments you need to do as you do regulations wasn't going to apply. But we did reach out quite aggressively with the Small Business Administration to help them understand what we were doing, sort of lay out our plan so that they understood what we were doing. Not that they were going to sign off or sort of say it was the greatest thing since sliced bread one way or another, but we did at least want to do that due diligence. And so for us, that's the two-pronged piece. There is the Ombudsman Office at SBA that we work with as they get comments in from providers, and we proactively work with them to tell them what we're doing. And as we roll the demo out nationally, that's a group that we will work with quite closely so that they understand the impact of what we're doing on the RACs. And not just on the RACs, whether it's regulations having to do with home health agencies or DME or whatever, we work very closely with that group to be sure that we're in compliance where we need to be with the Regulatory Flexibility Act.